Hey, welcome to the deep dive.
Great to be here.
Today, we're diving deep into something incredibly common, yet medically pretty complex. The influenza virus. You know, the flu.
Ah, yes, the flu. Everyone thinks they know it.
Exactly. And you've shared some fantastic MSRA revision notes with us.
Yeah.
So our mission, basically, is to slice through them, pull out the absolute highest yield info.
Make it stick for revision.
Make it stick. Get that core knowledge locked down tight. Okay, let's unpack this.
Sounds good.
Yeah.
The perfect topic, actually.
Yeah.
Because while it seems straightforward, the specifics matter. Understanding the virus, who's truly vulnerable.
And how we manage it based on the evidence.
Exactly, which these notes seem to cover really well. It's vital stuff.
Absolutely. So kicking us off with the basics, what exactly is this virus according to the notes, definition, etiology?
Okay, so at its heart, influenza virus is an RNA virus. Belongs to a family called Orthomyxoviridae.
Orthomyxoviridae.
Right. And it's what causes those seasonal respiratory infections, the flu. There are types A, B, and C mentioned.
A, B, and C.
But the notes emphasize that types A and B are the main ones causing most of the clinical disease we actually see.
Got it. RNA virus, specific family A and B are the big players. So how does it actually get around transmission?
Right. The main ways are through respiratory droplets, coughs, sneezes, sending tiny virus bits into the air.
Standard respiratory spread.
Yeah. But also direct contact, touching someone who's infected.
Mm-hmm.
And even indirectly touching surfaces the virus is on and then, touching your face.
Simple but effective.
Incredibly effective at spreading. Yeah.
Which leads us right to thinking about who's most likely to get hit hard by it. Here's where it gets really interesting. Who are the high-risk groups we need to flag?
Okay, this is absolutely key for revision. The notes list several groups.
I'm thinking age extremes.
Exactly. People over 65. And importantly, very young children, specifically under 6 months old.
Under 6 months. Wow, that's tiny.
It is. Also, pregnant women and women who've recently given birth postpartum, they're high risk too.
Okay. Ages, pregnancy, what else?
Then you've got a big category. People with chronic health conditions,
Right.
respiratory issues, asthma, COPD, heart problems, kidney or liver disease, diabetes, anyone with immunosuppression for any reason.
Makes sense. Their bodies are already working hard.
Exactly. And morbid obesity is specifically mentioned. Plus, the notes point out, just being in close contact or crowded settings ramps up the transmission risk.
So for exams, remember the age cutoffs, under 6 months, over 65, and those broad categories of chronic conditions.
That's the crucial bit to lock down. Yeah.
Okay. So once this simple but effective virus gets in, what actually happens inside the body? How does it cause all that misery, the pathophysiology?
Well, it mainly goes for the respiratory tract.
Yeah.
So your nose, throat, lungs, it infects the cells lining these airways.
Right.
And that infection triggers the body's immune response. You get inflammation.
Ah, the inflammation response.
Yeah, it's that inflammation plus the damage to the lining that causes those symptoms we feel. The fever, the cough, sore throat, aches, feeling wiped out.
And there's something about type A virus specifically, H and N. That sounds important.
Yes, absolutely vital, especially for understanding the bigger picture, like pandemics. Influenza A viruses, they're categorized by 2 proteins on their surface.
H and N?
H is hemagglutinin, N is neuraminidase. And this is critical because it leads directly to 2 concepts, antigenic drift and antigenic shift.
Okay, drift and shift. I remember hearing about these. This is why the flu vaccine changes each year, right? The drift part.
Exactly that. Antigenic drift is about small, gradual changes, mutations in those H and N genes.
Just tiny tweaks.
Tiny tweaks.
Right.
But they add up over time. Enough so that your immune system's memory from last year's flu or vaccine isn't a perfect match anymore.
So you can get it again.
Precisely. And that's what drives the seasonal epidemics.
Yeah.
We need updated vaccines to keep up with the drifted virus.
Okay, that's drift. What about shift? That sounds more dramatic.
It is. Antigenic shift is a major sudden change. This usually happens when, say, a human flu virus and an animal flu virus infect the same cell.
Like in a pig or a bird.
Potentially, yes. And they swap genetic material. They basically create a completely new subtype of the virus.
One that humans haven't seen before.
Exactly. Most people have no immunity, and that is what can cause pandemics.
Yeah.
Like the 2009 H1N1, the swine flu.
Right. So drift equals seasonal tweaks, shift equals potential pandemic. Got it. Memory tip. Link H and N to type A's variability, and no drift is gradual, shift is abrupt.
Perfect summary. Understanding that difference is fundamental.
That really puts the whole flu season thing into perspective. So knowing the biology, let's zoom out. Epidemiology. When and where does flu typically pop up?
It's pretty seasonal, as you'd expect. Northern Hemisphere, the peak is usually December through March, roughly.
Your winter.
Yep. Southern Hemisphere, it's their winter, so May to September-ish. Tropical areas, though, they can see it year-round.
And how widespread is it? The notes give numbers.
They do. Suggest up to maybe 15% of the global population can get influenza each year.
15%, that's huge.
It is. And a 10-20% seroconversion rate, meaning that proportion develops antibodies.
And we've had major events, the pandemics.
Definitely. The notes mention 4 pandemics in the last century. Specifically calls out the 2009 H1N1 swine flu.
Okay.
And even gives a specific European example from 2011-12. H3N2 was dominant overall, but H1N1 was more common in the severe cases in some places then.
Interesting detail. So remember the seasons by hemisphere, that rough 15% annual figure, and the pandemic concept.
That covers the key epidemiological points.
All right, let's get down to what it looks like clinically. What are the classic features? How does someone present?
The big thing the notes stress is the sudden onset. That's really characteristic.
Really sudden, then what?
The usual suspects. High fever, a cough, often non-productive, so dry.
Right.
Sore throat, definite body aches, that's myalgia. Significant fatigue, malaise, headache. Sometimes GI upset, maybe loss of appetite, anorexia.
What about a stuffy nose, runny nose?
Interestingly, the notes say nasal symptoms, like congestion, are actually less common compared to those other big words.
Okay, less nasal stuff. Any other variations?
Yeah, an important one. Fever might be absent in older patients.
Oh, good point. So don't rule it out just because there's no fever in someone elderly?
Exactly. And while the worst symptoms might only last, say, 3 to 5 days, the notes highlight that the cough and the tiredness, the malaise, they can drag on for 1 or even 2 weeks.
That lingering cough. I know that one. And how long are people infectious?
Generally, infectivity starts about a day before symptoms even show up.
Wow, okay. Spreading it before you know you have it.
Yep. And it lasts for about 5 days from when symptoms start.
Yeah.
But that period can be longer in kids and the immunocompromised.
Right, and what about the very young? Infants, do they look different?
Yes, definitely. Notes say children can have atypical symptoms, more prone to complications. For neonates and infants, you might see things like lethargy, poor feeding.
Just not themselves.
Exactly. Maybe pauses in breathing apnea, fever, but again, maybe not in the very young. Pneumonia, ear infections, otitis media, drowsiness.
So a different picture in the little ones.
Yeah. And swine flu, the notes mention, was generally similar to seasonal flu fever, general flu-like illness.
Okay, so memory points. Sudden onset. Core symptoms. Fever, aches, fatigue, cough, sore throat. Remember the tiredness can linger. And watch for different presentations in the very young and old.
That's a great summary.
Now with symptoms like fever, cough, aches, that could be a lot of things. This raises an important question. What else could it be? Differentials.
Absolutely crucial, because the symptoms overlap so much.
Yeah.
The notes list quite a few.
Like the common cold?
Yeah, rhinovirus is on there. Other respiratory viruses too, like RSV, adenovirus, coronaviruses.
Okay, other viruses make sense. What else?
More serious bacterial things need considering. Meningitis, pneumonia, even simpler stuff like pharyngitis.
So bacterial infections too?
Yes. And depending on travel history or location, things like malaria, dengue fever, plus other viral syndromes like infectious mononucleosis, CMV.
Wow, quite a range. Viral, bacterial, even tropical. So the takeaway is flu symptoms aren't specific. Keep a broad mind.
Exactly right. Clinical context is key.
So if you're not sure just based on symptoms, how do you confirm it's flu? What investigations are mentioned?
Well, often, especially mid-season, it's a clinical diagnosis. You just know it's going around.
Right.
But investigations are used, definitely, often for public health surveillance or in specific cases like in hospital.
What kind of tests?
Notes list a few. Rapid influenza diagnostic tests, RIDTs. They're quick.
Quick, but maybe not super accurate.
That's often the trade-off. Then there's RT-PCR, reverse transcription polymerase chain reaction.
Yeah.
That's more specific, can even identify the strain.
Okay, PCR is usually pretty good.
Yeah. For more detailed work, there's direct viral culture, immunofluorescence, using swabs or aspirates from the nose or throat. Also, paired blood samples taken 10-14 days apart, looking for antibody rises.
Acute and convalescent, Sarah.
Exactly. Standard PCR is also listed. And importantly, the notes mention rapid bedside antigen tests.
Like the ones you can do quickly.
Yes, but they add a big caveat. They have low positive predictive values.
Meaning a positive result might not actually mean you have flu.
It's less reliable, especially when flu isn't widespread in the community. So, for revision, know the quick tests, RADTs, rapid antigen, exist, but be wary of accuracy, especially that low PPV. RT-PCR and culture are more definitive, but slower.
Got it. Okay. Diagnosis sorted. How do we manage it? What did the notes say about treatment?
Generally, two main approaches. First, for most otherwise healthy people with uncomplicated flu, it's about symptomatic relief.
Like what?
Rest, lots of fluids, hydration,
Mm-hmm.
using paracetamol or ibuprofen for fever and aches, basically self-management.
To write it out at home.
For many, yes. But then there's the specific antiviral medications.
Ah, the antivirals. Which ones?
The notes focus on oseltamivir,
Okay.
probably known as Tamiflu, and zanamivir, which is Relenza.
Okay, oseltamivir and zanamivir. What do they do?
They can be used for treatment, so when someone's already sick,
Mm.
and sometimes for prophylaxis, preventing infection and contacts.
Right. Is there a catch?
Timing is absolutely critical for treatment. The notes really emphasize this. They work best if started ideally within 48 hours of symptoms starting.
Within 2 days. Okay, that's a key window. Is one preferred? Oseltamivir versus zanamivir.
Oseltamivir is generally presented as the first-line choice for most people needing treatment. Zanamivir is inhaled. It's an alternative.
And it's mentioned for severe cases, too.
Yes, or if oseltamivir isn't working in hospitalized patients, the choice can depend on the patient, the strain, local resistance patterns, perhaps.
What about how well they actually work? And side effects?
Notes say antivirals can shorten how long symptoms last and reduce the risk of getting symptomatic flu if used for prevention.
But do they stop complications like pneumonia?
The impact on complications is less clear, according to these notes. Side effects are mentioned, oseltamivir adverse effects noted, especially in adults. Zanamivir seems generally better tolerated.
Okay. Any special groups, like kids or pregnant women?
Definitely. Notes say oseltamivir can be used in children under 1 year old.
Good to know.
And for pregnant or breastfeeding women, both oseltamivir and zanamivir can be considered, but it's a benefit versus risk judgment call.
Right. And hospitalization for severe cases, obviously.
Yes, for complicated flu.
Hmm.
And oseltamivir is still first line in hospital. So key management points: rest, fluids, fever control for most. Antivirals are oseltamivir, zanamivir. Remember that 48-hour treatment window? Oseltamivir is generally first line. And specific considerations for the very young and pregnant.
Makes sense. Now, stepping back to prevention, what's the main strategy? How do we stop people getting it?
Vaccination. Absolutely number one. The notes strongly push for annual vaccination.
Especially for those high-risk groups we talked about earlier.
Exactly. The over 65, under 6 months, though vaccine usually given to mom or contacts for them. Those with chronic conditions, pregnant women.
Why pregnant women specifically again?
The notes highlight the risks flu poses in pregnancy, serious illness for the mother, plus risks to the baby, like preterm labor, low birth weight, especially if infected in the 3rd trimester.
Okay, vaccination is key. Anything else mentioned on strains?
A small detail. H3N2 tends to hit the elderly harder, while H1N1 can be more severe in younger people. Just shows how strains can differ.
Interesting. And what about prophylaxis? Using the antivirals before someone gets sick?
Yeah, that's described too. It's offering those same drugs, oseltamivir or zanamivir, to at-risk contacts who haven't been vaccinated or might not respond well to the vaccine.
After they've been exposed?
Yes. And again, timing is crucial, but different windows than treatment. Oseltamivir prophylaxis needs starting within 48 hours of exposure. Zanamivir within 36 hours.
Slightly tighter window for zanamivir.
Seems so. Oseltamivir is again first line for prophylaxis in at-risk adults and also for kids under 5 in those at-risk groups. Options for the severely immunosuppressed are mentioned too.
And the notes mention some specific guidance. NICE maybe.
Briefly, yeah. Clarifies it excludes pandemic advice. Importantly, it says don't use amantadine, an older antiviral.
Okay, no amantadine.
Reinforces using oseltamivir or zanamivir for post-exposure prophylaxis in the at-risk, restating those start times. 48 are oseltamivir, 36 are zanamivir. And a specific point about using them in residential or nursing homes during an outbreak, even if residents are vaccinated, to try and stop spread.
Right, controlling outbreaks in vulnerable settings. So prevention, vaccination first. Prophylaxis, antivirals for at-risk contacts, remembering the timings.
You got it.
So after going through all that, infection, symptoms, maybe treatment, What's the usual outcome?
Prognosis.
For most people, it's good. Notes say recovery usually happens within 1 to 2 weeks.
That's reassuring.
But they also clearly state severe cases can lead to hospitalization or, tragically, death. So prognosis is definitely better if you don't have underlying health issues.
Right. Which brings us to what happens when things go wrong. So what does this all mean, the complications?
This is a really important section. Shows why flu isn't just a bad cold. Complications can be grouped by system.
Okay. Respiratory first. Yes, common ones. Acute bronchitis, making existing asthma or COPD worse. Ear infections, otitis media. Pneumonia, that's a big one. Sinusitis.
Expected being a respiratory virus. What about non-respiratory?
This is where it gets quite wide-ranging.
Yeah.
Cardiac problems, myocarditis, pericarditis, inflammation of the heart muscle or sac, or just making existing heart disease worse.
Wow. Affects the heart, too.
Can do. Febrile convulsions, especially in kids. Muscle problems, myalgia, myositis, even severe muscle breakdown, rhabdomyolysis.
Or rhabdo from flu.
Was listed, and then a worrying list of neurological complications.
Like what?
Ray's syndrome linked with aspirin use in kids, but listed. Encephalomyelitis, transverse myelitis, inflammation brain or spinal cord, Guillain-Barré syndrome,
Yeah.
aseptic meningitis, encephalitis, and rarely toxic shock syndrome.
Gosh, that's a lot more serious and systemic than many people probably think.
Absolutely. And the note specifically reflagged the risks in pregnancy here. Too high risk for mom and baby, preterm labor, low birth weight, especially third trimester.
So when revising complications, think broad. Respiratory, cardiac, muscle, neuro, pregnancy risks. It's not just the lungs.
That's the key message. Understand the potential breadth of severity.
Any final practical points from the notes on follow-up after someone's been sick?
Just briefly mentioned undermanagement. Suggest considering follow-up for frail individuals. Advising patients to seek urgent help for specific warning signs.
Like worsening shortness of breath, maybe?
Things like that, yes. And arranging follow-up if someone's not improving after about a week. And just being extra vigilant with young children recovering. Practical advice.
Okay, so we've really pulled these notes apart. From the basic RNA virus, the H&N antigens causing drift and shift,
Crucial concepts.
through who's most vulnerable, that sudden onset of symptoms, the wide range of differentials, how we test for it,
Remembering the limits of rapid tests.
the management options, supportive care versus antivirals like oseltamivir, zanamivir, within that 48-hour window.
Key timing.
Why vaccination is #1 for prevention, when prophylaxis is used, the typical recovery, and that surprisingly long list of complications, respiratory, cardiac, neuro.
Even muscle breakdown and pregnancy issues.
For your MSRA revision, really focusing on those specific age cutoffs, nailing drift versus shift, the 48-hour treatment window, the main antivirals, and grouping those complications seems super high yield.
Exactly. Hopefully this deep dive hasn't just listed facts, but shown why these specific details matter.
Oh.
For understanding and for tackling exam questions accurately. Those timings, age limits, test accuracies, they lift your knowledge.
Definitely.
And, considering how fast this virus changes antigenic drift, antigenic shift, it highlights something interesting. Revising these core facts is vital, absolutely.
But you also have to stay current.
Right. Staying aware of current strains, current guidelines, is just as crucial in actual practice. It kind of raises a question, doesn't it? How do you balance learning this relatively fixed knowledge for exams?
With the reality of an ever-evolving disease like flu out in the real world.
Exactly. Something to ponder.
That's a fascinating point to consider as you continue your studies. We really hope this deep dive into your influenza virus notes has been incredibly valuable for your revision.
Hope it helps things click.
If you're preparing for the MSRA exam and found this helpful, you should definitely check out passthemsra.com. Loads more revision resources there.
Really useful site.
And remember, for free resources to help you on your journey, freemsra.com is also available. Worth checking out.
Good resources there, too.
Thanks for diving deep with us today.
Pleasure.
We'll catch you on the next one.